So thank you very much for including us in this discussion and for the introduction, Malcolm, that you gave. I think that there's so much we can learn from what the expectations are of the system, but also from each other. And I think you've heard, and with my comments are going to hear sort of very different but overlapping perspectives that hopefully you will be able to ask us questions and we'll be able to sort of share our experience. So it's interesting when the ACCME received the invitation, it really overlapped with efforts that we have underway to, as we describe it, leverage the power of learning. Leverage the power of learning for the individual, but also for the institution and obviously for the patients that are served. I included an article by Graham McMahon, our CEO, that was recently published last month in Academic Medicine. So if you haven't had a chance to read through that, I think that would sort of give you a perspective of where we are right now in our system. Just a quick overview, we manage a very distributed system of education. We have about 2,000 organizations that are accredited. Those organizations plan and produce about 150,000 educational interventions. They could be projects, they could be webinars, seminars. It's a whole range of types of education. I mentioned they're distributed across the country. We've recently started accrediting internationally as well. But what I think is most impactful about this data is that our system of education interacts with 14 million physician learners, right? There's learners, physician learners and other professionals who interact multiple times in education throughout a year. So that's an incredible number of touch points with healthcare professionals in any given year. Our requirements can be really summarized in the bullets at the bottom of this slide. And I want to call out the fact that yesterday the 2003 IOM report, Health Professions Education, A Bridge to Quality, was mentioned. That report was, at least for me personally, incredibly impactful. We were in the process back in 2004 and 5 of looking at our requirements, and there were points, recommendations in that report that talked about accreditors and what we needed to do to make sure the education was relevant to practice, that was measured for change, and also importantly that we were coordinating. We were aligning and coordinating with other accreditors, with credentialing bodies, with license bodies. And so we've spent the time since then really focused on those efforts. Our standards are really simply that the education is designed to change. We moved beyond knowledge with our 2006 requirements. It is no longer acceptable for the education to be designed to change and evaluated for change simply in knowledge. We felt that it was important that education move to knowledge in action. So what are you going to do with that information? What are you going to change? What are you going to stop doing as a result of what you're learning in accredited education? Our standards, as I was listening to the presentations yesterday, our standards are almost parallel to the business case, right? You sort of identify the problem, you figure out the appropriate venue to make change, you determine the facilitating conditions, the barriers, the costs, and then you measure the impact. So we've really structured our requirements around that as a model. But I want to spend a little time explaining something that we recently announced. Last year, after about 2 years of study, we released a new menu of commendation criteria. So as accreditors, we have a few tools at our disposal. It's interesting, Malcolm, maybe it used to be sticks. Now we're trying to provide incentives and rewards. We're trying to push and pull the community to reflect what we think will be most impactful for learners and their patients. So this new menu of commendation criteria, it's divided into 5 themes. And our accredited providers, if they want that gold standard, if they want extra years of accreditation, instead of 4 years, it's 6 years, they can seek to achieve accreditation with commendation. They're divided up into these 5 themes: promotes team-based education. It's in here that we ask providers to incorporate patients as planners and teachers, which is what we talked about yesterday with Mr. Siegel. We ask providers to address public health priorities, to enhance skills, to demonstrate educational leadership, and to achieve outcomes. Not just to measure outcomes, but to actually be able to demonstrate that performance, healthcare quality, or patient community health has changed as a result of the education. In the article that I mentioned that Graham wrote, we're making the business case for accredited continuing medical education, or in the case of my colleagues here, professional education, that it be cost effective and a powerful catalyst for change, that it create and support teams, that it improves the well-being of the clinicians, because if clinicians are learning together, changing together, improving together, they will take care of each other. It engages the clinicians in the institutional priorities where they work or learn. It facilitates processes to empower clinicians to bottom up QI. Oftentimes we see the quality improvement efforts coming down on the clinicians, and the clinicians not really engaged in identifying what they want to change, what they need to change. Improving referrals to appropriate and necessary treatment options. As I mentioned, engaging patients and teams in care decision-making and improving quality and safety. So those are the business cases that we're making from an accreditor about the value of accredited CME. This is just some examples I've included. These are examples that I've included in my handout. I looked for 5 different examples from education that has been submitted by our accredited providers, and I just highlighted the change that was demonstrated. I see from yesterday's discussion it would be really useful to start to dollar and cents those changes, right? To determine what the cost savings were or the benefit from those changes. So I offer those as examples of real life work that's going on. Lastly, I'm just providing some resources to you in case there's more information we can provide. I mentioned yesterday, just very briefly, joint accreditation as an effort that we're engaged in with nursing and pharmacy, again, to sort of promote interprofessional education in support of interprofessional collaborative practice. So I look forward to your questions.